case you need water, you can open it.
Thank you so much for inviting me. As I was coming over here this evening, I was thinking about my roots here, if you will. And actually, a lot of my professional life and my career, many of the things I'll be talking to you about, really started on this campus. I came here not knowing what I wanted to do or where I wanted to go, and I was very influenced both by the faculty as well as several students, some of them friends of mine from high school, but others that I'd met from around the state. And I'm sure that continues to today. So I'm going to be talking about problem drinking at colleges and universities, but I'm going to do it from a little different perspective. I'm really looking at sort of a public health preventive model. What can we do to head this off from the beginning? And as we'll go on, and I'll tell you some of my disclosures here, you'll see how where I've been and what I've done really has been a building of that. So right now, this is the things that I'm doing right now so you can see what my biases are. I'm really disclosing my biases in going through this. I'm a do-gooder in the sense that I'm a clinician, and you always want to watch out for do-gooders. You never know what they're going to do next. But I also have tended to come at the whole issue of how to build a career and how to pursue the things I was interested in from the standpoint of public health, anthropology, which seems a little bit discordant from both general practice, where I started, but also from psychiatry. But perhaps by the end you'll see how these things can be brought together. And then over the years, the things that I've done, some of them really relate quite strongly to what I'm going to be talking about today. So the first one up there, my work at the University of Minnesota Medical School for about 20 years, really laid the foundation for starting curriculum in addictions, starting some new services in addictions when those didn't exist before, and then also trying to build faculty around that. And at that point I was lucky, so were about 60 other young faculty members at medical schools around the country. We all received grants for 3 years from NIH to develop curriculum, develop services, and develop faculty in this particular area. It was a time in our country's history where there was a phenomenal amount of addictions coming out of the 1960s, early 1970s, and the government wasn't having much influence on changing anything. They had more and more laws, bigger and bigger prisons, and nothing seemed to be working very well. And so they did pour a fair amount of money into health centers around the country to do something about it. The other thing that, background that I think is relevant to the topic tonight is my work with the U.S. Army after over about a dozen years. Because people, as they come to the Army, are sort of like students as they come to your campus. They're very much shaped by their communities, their families, what they come from. They come from all over the country. And they're there temporarily. They're going to be in the service for 2 years or 4 years, but not forever. And it's very much a time when they're growing up. And part of growing up is learning how to open a bank account, learning how to fall in love, but also learning how to use substances. And they're doing that in the Army. So a lot of my work with the Army over a dozen years relates to that. And then, of course, work with the airlines and work with physicians groups that can make me talk a little bit about them. So then the nature of the problem is going to be the first of the 3 points that I'm going to try to highlight here. And the nature of the problem is something that as you get into doing this work, you don't have to discover all of this again. A lot of it is already there for you. The nature of young age substance use, but also young age substance problems in our country, in our culture, but also around the world. It's been very well defined over about the last 40 years. So this doesn't take a lot of effort. It does take a lot of reading to kind of access some of the information. Countries and cultures, colleges that have done well with this problem, and others that have seen the problem expand. So I'm going to go through not all, but I think some of the main points about college-age substance use disorder. And you'll forgive me for using jargons. I've really tried to keep my jargon to a minimum, but nobody working in these things in academic or governmental centers like the terms alcoholism. They don't like the terms drug abuse because it sounds bad. So substance use disorder has come out of that. I think probably give it 5 years, it'll have all the negative connotations that addiction has, but that's what we've got right now. I'll try not to use it too much. Now, substance use disorder can begin at any age. I've seen it begin in grade school, and I've seen people first develop it in their life in their 70s. But by and large, in our society, most societies in the world, it really starts during adolescence, particularly the last half of the teenage years, and through the 20s. And this is where people are learning to do this adult thing, which is how to use substances, how to enjoy substances, how to participate in celebration, how to use them to treat or heal, but also to do it without getting yourself in a lot of difficulty. And very early on, the human family learned that substances were difficult and could cause troubles. So that one of the first written laws, the Hammurabi laws, have some phrases in there, some quotes in which alcohol use, if you do something that's going to cause other people trouble and you're using alcohol, the punishments are worse. Even the Aztecs, more recent translations of the Aztecs indicated that Aztecs had certain limitations about when people could drink, how much they could drink in relation to their age or to their social standing. And so people think of the Aztecs as maybe not being very sophisticated, but the first laws in the old world, the first laws in the new world, both had very specific laws about how and when you could use and in what amounts. Or if you did something harmful to others, whether that would affect the punishment that might be meted on you. The other thing is early onset of substance use problems doesn't affect us all the same. This is not an equal opportunity disorder, unfortunately. And I think as an American, that's hard for us to swallow. I mean, we want all the fruits and the goods to be equal access. You know, all of the miseries should be equal access to, but they're not. So your students come to campus here with all kinds of sets ahead of time that they can't change at that point in time. And I've listed some of them here. And then lastly, for this side, college attendance is itself a risk factor over the last few decades. Before that, during the first few decades of my career, college attendance was a protective factor, but it's turned since then. Another indication of how when you're looking at socio and cultural things, things can change, and they can change rather suddenly and unexpectedly. I don't think anybody was expecting this. Whereas if you're dealing with genetics, things change more slowly over generations. Next. The next thing I want to indicate is how the nature of problem drinking is progressive. It's got a long time for most people in which it continues or evolves. So one is to look at the patterns of problematic use. And I'm using now the pretty international kinds of descriptions that are used: binge, 4 or 5 drinks in one setting; heavy drinking, 15 to 22 drinks weekly; crises that come out of drinking in various amounts. Somebody can have a crisis they're trying to fly an airplane on 2 beers. That could be a very serious problem. Other kinds of crises roll out of somebody consuming a case of beer and then go out and getting into trouble of some kind. So there's these different patterns that are associated with various kinds of problems. The second thing to take into account is diagnosis. So drinking, and even drinking heavily or binge drinking, isn't necessarily a diagnosis in a sense. So a diagnosis usually involves a problematic use pattern, such as those patterns that I've just listed for you. But they also include a consequence of some kind. Person knocks over a fire hydrant or gets in a fight or drinks longer than they wanted to drink and has consequences related to that. And then the third indication is that there's a persisting use despite the consequences. So you might say in most of these definitions or most of these criteria, you get one free shot at a problem. I guess we all have one fire hydrant, but the second one isn't a freebie. You're apt to pick up the diagnosis. The good part of this, having a diagnosis, it's labeling for sure, but it's a way of tapping into public health laws. It's a way of tapping into health insurance so that you can go to a clinician and get care and help for this. Whereas if it's not a diagnosis, that isn't necessarily the fact. Next. So more about the chronology. And one is the average time from the onset of problem drinking to the beginning of treatment seeking. So one of the downsides of many, many of the chronic illnesses, including this, is that there's a long, long period from your first indications or your first sticking your foot in the water, having problems, until finally you go and get treatment for it. And this is true with hypertension, it's true with elevated cholesterol, it's true with obesity, it's true with HIV, it's true with tuberculosis. So this should come as no surprise. But I think it did come as a lot of surprise. I think people felt, well, as soon as you got it, you would know about it, or others would know, and treatment would be right around the corner. But it isn't. Now, interestingly enough, it's fairly long for substances like alcohol. Interestingly enough, it's also true for opium smoking. It takes you about a decade. But it's very short for some of the more purified substances that kind of foster the evolution of addiction fairly fast. And substances, when you use them, they impair you longer. So that heroin is a much more addictive substance than, say, alcohol. Hits people sooner, the same with cocaine. The second point is how these patterns differ by age. So people in their teens and early 20s, they're much more apt to have episodic use. They have problems in the social or the behavioral realm. And they're also at an age when they can, and they do, transmit it to others. And so people don't think of drug and alcohol problems as transmissible or, in quotes, communicable, but they are. So that in societies where nobody uses in this fashion, people don't. But where they do, it's something that's learned during this period of learning substance use, the late teens and the early 20s. Whereas the subsequent pattern as people get into their 30s, 40s, and 50s is more chronic use, daily or very often use. Pilots, for example, will drink heavily when they're not on duty. Physicians will drink in the evening. Attorneys will drink in the evening. College professors drink in the evening. And the consequences are more medical. So you start to see liver troubles, but also endocrine problems, diabetes mellitus, hypertension problems, beginning in that later age, whereas we're not as apt to see them very early. And then as people become older, they become less communicable. And anybody have any ideas why that might be? They do drink alone. A lot of their buddies, as they go along, don't hook together, or there's a death rate. So they're drinking alone. They may be drinking secretly, so your average attorney doesn't want everybody to know it down at the local bar, their clients to know that they're drinking heavily. So some of it's that. Some of it is that they're really getting into some pretty serious heavy drinking, and it can become costly. They don't want to have to buy a bottle of scotch every night for their buddies. And so in a sense, from a public health perspective, those people aren't as transmissible, aren't as, in quotes, risky or dangerous to society as the young person who is getting in with a lot of other young people. And part of the dilemma, of course, for the colleges nowadays is that you have people coming to college who've already learned risky drinking in high school. I mean, it used to be that there were very few high school students who knew how to drink in a risky way. And that is no longer the case. So I don't have any idea exactly how many students like that there are coming to your particular college, but I know nationally this is a big issue. So it isn't a point of do you keep it out, it's, you know, what do you do because it's going to arrive. Next. So I just want to go over a little bit so as to make clear with you how these substance problems are transmissible. And not transmissible with body fluids, not transmissible in sewage or whatever, but transmissible in psychosocial relationships. So one is this occurs with the people that you care about and love the most, your friends, your roommates, your peers, maybe the captain of a team that you'd like to be on. But also it can be built up by institutional culture and the mass media. So we don't see as much ads as we used to about alcohol, but they're still around. And to some extent that's the result of laws. But the mass media, what you see in movies and TV, creates an aura that young people are brought up in. So you've got attitudes and values developing before people even know what attitudes and values mean. So in the beginning, as people are with a group in their teenage years, the group is deciding the occasion for their drinking, the location, the amount they'll use, and the type of substance. And it takes a fairly strong character to maybe be with them and not go in the same direction. It's not a simple thing. And in some grade schools now, they're even trying to start to teach young kids how to be with a group and not necessarily get sucked into their behavior. So I think it's very important to think about this age of greatest transmission as being the time when people are apt to be using to cope, to deal with social anxiety, to find respite from whatever is causing them the greatest concern. And it's oftentimes at a time when they're the most healthy and the most attractive personally that they're going to be in their life. So in a sense, they're very influential to other peers. And then transmission falls off as they age. Something similar too with HIV, by the way. So the next realm that I'd like to talk to you a bit is coupling the nature of youthful drinking with the extent of the problem. And if you talk to public health people, they can boil down their science, their kind of esoteric, sometimes hard to understand science, into two things, nature and extent. And everything in public health, everything that's got to do with prevention is what is the nature and extent of the problem you're trying to approach. Because that's going to govern everything. That's going to govern the cost. It's going to govern how soon or how long it's going to take you to be successful. And one of the dilemmas that we have, not with all of our public health problems, but certainly with alcohol and drug problems, is trying to discover the extent of the problem. So I put down there, don't just do something, stand there. The opposite of what you hear. I mean, you think about preventing, you think about public health, let's get out there and do something. Well, that's fine, but first don't do something. Learn the extent of the problem, because you may be throwing too much resource at it, or it may be like going hunting, elephant hunting with a pop gun, you know, forget about it. Next. So what am I talking about here in terms of why the extent is important? And this, I'm trying to relate the prevalence, the current active prevalence in a population of interest, say the students here at St. Thomas. And about how many students have we got currently? 7,000, 8,000 maybe? 6,000, okay. 6,000 undergrad. Well, we can include the grads. 7,000? Huh? 4 undergrad. Oh. So 6,000 altogether. So if the prevalence was 1 in 10,000, you don't have to worry too much. I mean, even if we're talking about HIV, tuberculosis, lots of conditions, 1 in 10,000, it's something for a federal office to kind of keep track of, but it isn't to worry a lot about, because at that low a level, transmissibility, I mean, it's so many deviations away from normal that it just doesn't spread. The people having the disorder tend to be isolated. It doesn't spread very rapidly, even in naive or low exposure populations, and so the risk is low. Out of, say, 6,000 students, it'd be a half a student. So, I mean, the odds are you wouldn't even have a person on campus with this. Now, if it was 1 in 1,000 people, you'd have 6 people. And at that point, 6 people can be transmissible, because you've got 6 people, even split them into 3. 3 people can be influential, and you can get spread out of even 3 people. And so 6 people are far more risky to the population at large than is a half a person or an outsider or 1 person. So either that 6 is either shrinking because there's been a program to reduce the prevalence of the condition, or it's beginning to expand. So it's unstable, and it's something to be concerned about. It's a more tricky area, and I'm not going to talk about it a lot tonight because we don't have a lot of this in our country right now. But for example, between the end of the first, call it youth drug epidemic in this country, the 60s and the 70s, and then the next one, which is more like the 90s in sense, there was a period in there when a lot of the data around the country, a lot of the opiate addiction, for example, around the country was down in this level. Epidemic is 1 in 100 people. So if you had 6,000 students, you'd have 60 who were transmissible if it was at this level, at 1 in 100, 1%. Now, 1% of almost every major condition costs the society a lot, because that 1 person and the dilemmas that result are very pricey for any chronic condition of any importance at all, including tuberculosis, for example. So epidemics are important, and not just to people like myself, but to society at large. They cost us a lot of money. And there's always the risk that you can get an endemic, that it can go up to 1 in 10. So if it were 1 in 10 out of 6,000 students, you'd have 600 students. Is that even possible? Well, it is. Say if you had 100 students among the freshmen as they're coming in, and then 200 in the second year, and 200 in the third, 200 in the fourth, you've got 600 students. There were, let me say, when I started working in this area, there were very few substance abuse endemics around the world, not a lot. China and opium, up to the time of Mao Zedong's taking over, would be an example. American Indian drinking in certain tribes, but certainly the tribes in the upper Central Plains, had rates this high. There's some others around the country. There are counties, even here in the United States, that have rates that high. But by and large, around the world, we don't see an awful lot of rates that high. By the same token, if any of you have read the NIAAA information about college drinking, they're saying as many as 20% of students in some colleges are really into binge drinking already. And I'm telling you, it isn't quite a diagnosis yet, but it readily translates into a diagnosis before too long. And I don't want to bother you with the details about that. But endemics, you want to avoid an endemic if at all possible. I have no idea what the rate is here at St. Thomas, and I'm sure some of you are probably concerned and thinking and have some ideas about that. Next slide. The obstacles to learning about the extent are very great. And one of the problems is that there's no one test that or indicator that will tell you about whether you have a case in front of you. With a lot of the infectious disease, for example, typhoid and all of those, there was a simple skin test. With TB, there's a skin test and an x-ray. There's a lot of ways of chasing it down. That isn't so much the case. So what do? One of the common things is to rely on surveys, but and you can get pretty good survey data by guaranteeing anonymity, privacy, and confidentiality. By the same token, the validity of the survey is limited by the person who's providing you with the data. And particularly if they're early on in their disorder, they are thinking everything is just fine here. You really got a problem of their denying that this is the case or feeling irresponsible about it. They may suspect maybe they have the problem, but they don't want to put it on paper. Or they're blaming somebody else. Well, yes, I have this problem, but my father was an alcoholic. What do you expect? And so that in itself is a dilemma. One of the things we see in treatment, for example, is with these surveys, from the start of treatment until people are, say, through treatment in 3 months, is the rate of their alcohol and drug-related things go up while they're in treatment, even though they're not drinking or using drugs. So they just become more insightful that argument with their boyfriend or their girlfriend, that car accident where they dented their father's fender and he was so irrationally upset about it. I mean, they're beginning to see how they've got a chain that they're dragging along with them, whereas early on as they get into treatment, they're not responsible for this at all. It's somebody else's problem. And then there are the objective indicators that can reveal not the exact number, but change over time, and also the qualitative nature of the change. Do we have more vehicular problems, or are we having less as the parking is easier to access, as people can take buses or things are nearby? Are we having less vehicular problems? Next. I just want to stop kind of the general things I'm telling you and go into something specific, and that's the ways of counting the extent, incidence and prevalence. And part of the problem is you hear all of these numbers, and the dilemmas are that they don't always mean the same thing. So let me get off of students and talk about people, people like me, physicians, and we'll talk about their incidence. So the incidence number of new cases per year of substance abuse among physicians is pretty low. Now it's going to be very high in your freshman coming here to St. Thomas or joining the Army, because you have this huge number of people who don't have the diagnosis yet. Also, physicians, they have to be in their late 20s to get in the ranks, you might say. So many of them have developed it before they even got there. And so the incidence is really pretty low. The current prevalence can be quite high. I think probably now in most states it's down around 1%, maybe a little over. When I first got into this field, it was up around 2 or 3% of practicing physicians met criteria for alcoholism or drug abuse. Now, lifetime prevalence involves the person's whole lifetime. So a current prevalence might be of 2 or 3%, but the lifetime prevalence, including those who have recovered, those who maybe died, may be much higher. So among physicians, 6-8% nationally was not uncommon. And then lifetime risk, it's a more difficult statistic to measure, but it's whether this person throughout their lifetime, through the years when they could develop an addiction problem, where they didn't die when they were 15 or something like that, what's that risk? And that risk was around 15%. So you have one group here with an incidence under 1% and a lifetime risk of 15%. In many of the groups that are running like a 20%, or pardon me, a 10% prevalence rate of alcoholism, like American Indian people, like some of the opium smoking groups in Asia, that means that the men, by the time men die, their lifetime risk is going to be about 50 or 60% that they will have had those problems during their life. Among women, usually less, maybe 20, 30% in that range. So just think of what that would do to a society, what that would do to the life trajectory of half of the men and a third of the women in some of these societies that have this very high rate. It becomes devastating. Next. Next, I'm going to talk about the third and last element, and that's how to intervene. Given that the nature of the problems are of a certain kind, the incidence is a certain type, how to intervene. What can you do about this problem? But before I go into the last one, does anybody have any questions to clarify what I've said up to this point in time? Have I said anything that seems a little confusing or internally conflicting? Well, why don't we go ahead? The interventions gets to be a little bit more complicated here. I'm dividing it into those 5 categories, as you can see. Talking first about preventive interventions, which are primary, secondary, tertiary. This is getting into jargon again, public health jargon this time. So primary prevention is preventing a disorder so that it never occurs. And you have societies in the world that have almost nil, or do have nil, rates of alcoholism. So in those societies, alcoholism never appears. The advantage of this is that it eliminates that period of risky use before the person even thinks about doing something about the problem and seeks treatment. So you eliminate all of that risk and all of that negative events from the population. It's most effective. If you can primarily prevent anything from TB to depression, the amount of money that saves is extensive. And it eliminates transmission, because no one's going to catch this. Now, secondary prevention is early prevention. So rather than wait until somebody has hepatic cirrhosis, you try to intervene when they're in binge drinking, for example. And if you follow the diagnoses over the last half century, what's happened around the world is that the diagnoses are aimed at picking people when they're younger and younger and younger. Now that, or I should say, less and less time spent in their pattern of risky use. And so it's taken a lot of time to collect data to justify that, because you're committing the insurance companies, the medical and health resources of a country, the money of a country towards intervening early. And, but that's where things are headed, to try and do early intervention. So this is probably where we're going to get the most bang for the buck. Tertiary prevention is treating the people who show up, and this is the least cost effective. Treatment is much more expensive when people now aren't just risky drinkers, but now they've got liver problems, or now their children are having difficulties in school, or you got fetal alcohol syndrome, and those are all very expensive interventions, lower success rates, and they don't do much about transmission either. The little kid with fetal alcohol syndrome isn't going to pass on a lot of active cases or alcohol or drug abuse. So in a sense, you're sort of perpetuating the problem if you're spending all of your money here and none of your money up at the preventive times. So what could be done in a university to help people learn more about primary interventions? What could be done on an individual or a group level? So one of the things we did in the medical school fairly early on was to, and the other health sciences schools, was to teach students how to decide what their own unique risk was. So they get the notion both in themselves, but also in their friends and peers, and in their future patients, how we all carry a somewhat differing risk. And so the notion that some people have great willpower doesn't seem to factor out as a big deal in all of this, I'll tell you. But we all carry certain loadings, you might say, that we don't have a lot of choice about. The other thing that can be done on a primary level within a school is lectures, courses, or even minors in addiction services. And those are some of the courses that could be used in those lists under there. One of my favorites, by the way, is Midbrain and Addiction. If I had the time and energy to start a course, I think I would start that. One of the heads of one of the National Institute of Drug Abuse, is a woman born and raised in Mexico City. By the way, her great-grandfather was Trotsky. Does anybody remember Trotsky? The leader of the White Russians, who Lenin eventually won the battle. Trotsky escaped to Mexico, and Lenin sent an assassin to kill Trotsky in his home, killed him with a knife in the living room. And then Trotsky's son and Trotsky's grandson both had very bad cases of depression. Trotsky's grandson became an alcoholic and committed suicide. And so his daughter, a wonderful woman, is now the head of our National Institutes of Drug Abuse. And when she talks about drug abuse, she's a great teacher too, by the way, she talks about it stealing the midbrain. And really it does. The midbrain is kind of halfway in between our vegetative, human, animal functions and our cortex, both our old paleocortex, the old primate cortex, and our neocortex that makes us so human. It's stuck right in those two, but that's really where all the substance abuse have their great, great effects on us, and mostly out of our awareness and our consciousness. But there's many, many other kinds of courses here that can be devised and are being devised in colleges and universities around the world. Next. If I was going to be starting a secondary intervention in a university, well, we can teach people, and I did this too, teach people how to conduct a personal intervention with a friend, with a family member. And interventions were something that the AA subculture in the United States and England developed the intervention. Let me say sometimes those interventions were too heavy-handed. They could be risky. One of my residents when I was young, her father, a pediatrician, had a real heavy-duty intervention done on him. About 20 people who were the people in his life who meant the most to him. And part of these intervention orchestrations, I mean, almost like orchestrating a musical group, was for the person to go marching off to treatment. Well, this particular doctor, and I knew him, he's a little headstrong, he didn't march off to treatment, but he went home at the end of the evening with his wife, and he killed himself that night at home. And that wasn't unusual. That's the one I know the best because I know many of the people involved, but it was very common. So, I mean, this is a little bit, many people who know this background about interventions is you're going to let students intervene on students. Well, it can be done. It can be done safely. And it's pretty safe if just one person intervenes with another person, because the individual who is the person with the problem can say and convince himself or herself, this person is really stupid. This person thinks I have an alcohol problem. Here I am. I'm the most popular guy on the block, and they think I'm a drunk. Boy, are they jerky. So it isn't quite so dangerous, and it's much better if people are going to give up their denial and their delusions about life. It's much better to do it, you know, day by day, one a week, one a month, rather than my poor pediatrician friend who was knocked off his pedestal, you might say, by everybody he knew and everybody whose judgment he valued. The other thing I would think of teaching, and we did this, is how and why to quit risky use and teach them what might be safer, not that there's any completely safe use, but how to think about safe use. Next. And then tertiary interventions that could be taught. One is how to make a diagnosis. That's the first one, pattern, consequences, and inability to stop. Secondly would be how to build a recovering community within the medical school. In fact, we did that. We had students who were leading this within their different classes on how to build a group who was recovering. By the way, when I first started doing this, I failed in so many ways the first few years. And the first successful thing that happened to me is a medical student came up and said, I've got some ideas. And I said, well, I think I need ideas. Let's go have a cup of coffee. So we went and had a cup of coffee. And she was an AA member. She had gotten deep into alcohol and drugs in high school, recovered during college, and now she was in medical school. And she says, I have some ideas about some things we could try, which ended up being very, very, very successful. One of them having to do with creating a recovering community within the medical school, which really fostered heavy drinking after tests and, you know, in a variety of times during the years. And by the way, this woman who recently retired went on to be the president of the Hennepin County Medical Society and was repeatedly elected, and was the president of the Minnesota Medical Association. I mean, she really, I think from her experience in medical school, really learned how to play an audience, you might say, and how to think big, think programmatically, and think change in many, many other areas besides just alcohol problems. The other thing is to set an institutional framework that is pro-recovery. And so what do institutions do, like the medical school? Well, they do set limits, and they do negotiate contingencies. And if you can do those two things, you can really make a big, big impact in people who are beginning to have significant alcohol or drug problems. The other thing they don't do is enable. Just keep that term in your mind for a little while, and I'll come back to that. And they don't rescue. And believe me, it sounds like don't doing something is so easy. But if you're a helper like I was maybe born to it, I don't know, but I was certainly trained to be it, you can really goof things up by enabling and rescuing. Next. Now, I don't want to be anti-treatment because treatment pays my rent. I mean, I'm a clinician most of the day. That's my daily bread. Most of my life I've been a clinician. But here's some very common overview. I mean, there are exceptions a little below this. There are exceptions a little above this. But just treatment plus having a job, being occupied. And by the way, parenting is a good job, and going to school is a good job. But having any of those things gives you about a 30 to 40% chance of being sober and recovering at the end of 1 year. If you have a sober resident, you're living with a family or you're living with recovering peers, but you're not occupied, but just that alone, you don't have a job, maybe you're volunteering, that'll give you a 30, 40% recovery rate at the end of a year. If you have both of those, it doubles. It's kind of amazing. Most things in healthcare don't work like this. So you're up around 60 or 80%. You're really talking some big numbers. Whereas if you have just one of those, no matter what the treatment is, no matter what the nature of the problems that the people bring into treatment, even in prisons there have been outcomes like this. The outcomes have a lot to do with who are your resources while you're out of treatment and trying to recover, or who are the people who are trying to pull the rug out from underneath you and have you go out and have a good time with them. And so next, levels of intervention. What can you do as an individual, a group, or systems? There are things that can be done on an individual level. And I think teaching our students about that, teaching our society about that. We as you as a parent, as a friend, as a neighbor, can do helpful things. I wanted to mention ACOA. It's the Adult Children of Alcoholics. It's big out on the West Coast where it began. There's a little bit of it here in Minnesota. But I think the nice thing about it is you have people in that organization, some of whom have become addicted themselves, but others haven't. But they have a lot of the same problems in living as one another. So it's a way of not just stigmatizing people who have had addiction in their own lives, but it brings to the forefront that even if you haven't had addiction, but you've been raised in an addictive family, you carry a lot of the same stigmata. And about 3/4 of people who come to our attention or care clinically have an alcoholic father or mother. Actually, about 1/4 have both, about 1/2 only have one, and 1/2 have neither. So, I mean, you can get this without having a parent show you the way. But 3/4 of the people coming to treatment are, if they grow up and become adults, they're the adult children of alcoholics. And I found that that really sold nicely on the campus when I was trying to get it going. And how can individuals intervene? One is just by doing our jobs. That took me probably a decade to learn, well, 5 years anyway, in my own role. One is the role obligations we have as parents or supervisors, and you have to be willing to devote time. So if you're too busy, it's too bad. It's something you can't do right now. Groups can intervene. And Groups tend to occur in sectors, and sometimes sectors like the police, the courts, the government, the community, that's like a sector. Sometimes they can carry on certain things in common, helping one another out. And they can do all the things I've been describing here. Groups are rich enough, diverse enough, they can really do a variety of things. Next. And then systems. Systems-based interventions, I think in the long run, are more efficient. This is such a huge thing that I'm amazed that I did it years ago. I mean, I think if I was smarter or I knew what I was going to get myself into, I wouldn't have done it. Maybe that's like becoming pregnant or something like that. I don't know. It's better that you just go and do it. But it's too complex. And in the beginning, when the government began to be alarmed, they would have an alcohol czar, or other countries would have a heroin czar. Actually, there was an opium czar in China about 200 years ago. It was like a secretary in the government. And it's way too complex to have an alcohol czar. What we have now in our government is we do have an alcohol drug czar, but he has no budget. He has to go and talk people into doing things. And he's got the president behind him, of course. But then the people closer to the problem, who know much more of the nuances, know how to spend money in that particular sector, do it rather than the czar. I'd like to mention the carrot and the stick strategy. I'll call it the stick and the carrot strategy. When I first started working internationally, I found that a lot of people, as we would sit down and start talking about this, and usually I'd start with the Director General of Social Welfare, the Director General of Health, and we talk about how to get people into treatment, and we would talk about something like the stick and the carrot approach, and they say, wait, this is two different models. How can you be pressuring people here, and then you're going to help them here? That makes no sense. And I think that you have to leap over that and make sense of it before you can put a system together, so that you can both be a tough mother or father who isn't going to hand over the keys to the car, and a loving mother and father who is going to spend more time with that youngster over the weekend. So, and then as you get into systems, you maybe have the police pressuring the population in a certain way. And then you have the helpers like me starting an educational group or a self-help group for the people who get DWIs. So then in some communities, Massachusetts, for example, everybody with DWIs was given a warning. No accountability. And then someone said, this maybe isn't such a good idea, and they went it to a series of educational things. And then to stay out of jail, they had to be on probation for a time where they would follow up with people about how their use was coming, which really hit the DWI problem that they had in a very big way. Scandinavia did the same thing. So part of this whole business is to get the people that you're working with to understand and accept carrot and stick, or stick and carrot, because the stick has to come first, or carrots aren't that good. I mean, this isn't like malted milks. This is like carrots. You know, people say, oh, I wish I could go see a psychiatrist. It'd be so much fun, I could relax. Believe me, having done this kind of work, I don't think going to a psychiatrist is much fun at all. And maybe is occasionally when people round up, round a hill and get someplace with a problem that they're facing. But to me, it's a tremendous amount of work. It is not fun. So at best, it's carrots. It's not malted milks. Next. Linking the intervention to the prevalence. So if we're talking about an epidemic, you can use all the preventive things, primary, secondary, tertiary. However, when you have 1 in 10, you should think carefully about tertiary, because you may just have to throw a lot of people to their disorder because you can't afford to take care of them all. So in a lot of countries around the world, as they were hitting their HIV problem, earlier when they were doing their TB problem, they had to forget about treating people. People who were dead, dying, people who were on their last sticks, they got quarantined someplace, a lot of leper villages, and you just had to let them go because there wasn't enough money to take care of them, do early intervention, do immunizations and other things. And the same thing would apply to priorities. So they're very different interventional levels. And then planning, implementing, and evaluating. This is kind of the sweet spot of interventions. This is where you really have to be thoughtful about what you're going to do. This isn't just thinking theory and endemic. This is getting down to what are we going to try, and understanding that this may fail from the get-go. This may go nowhere. This may have unanticipated negative consequences, but trying it out anyway. Next. Things are getting a little late here, so I don't want to spend too much time with this. These are just a few interventions that I did in my life. Give you an example. One was we had a local airline that was firing all of its alcoholic pilots. And at this time, most of the airlines in the country had developed a different approach, trying to detect them early, work with the FAA, work with treatment. ALPA is the Airline Pilots Association, like their union. So they were trying to work with the airline, the union, and the FAA to develop ways for people to come forward and get treatment. This one airline wasn't. And so there were things showing up in the newspaper from time to time, passengers smelling alcohol on the breath of their pilot, two pilot and a co-pilot flying in from Bismarck. Both of them had elevated blood levels. It's amazing they were able to get here. I think they were very good pilots. And so that all changed eventually, not long after this story of the two pilots who flew drunk. That all changed, but it really took a corporate change for them to make that turn. And then suddenly people started appearing and recovery. I don't know if you've heard of Birds of the Feather, but Birds of the Feather are pilots who are in recovery. It's a great operation. And as a clinician, I'll tell you, I treat a lot of pilots in my life, and it just is phenomenal to work with those people. The recovery rates with a lot of pilots around the country has been up in the 80s and 90%. Nobody thought that was possible, but because of this three-tiered approach, and pilots love to fly, and you know they love it more than the drinking apparently, and they recover well. Another one was the Minnesota Medical Association. A bunch of us, I was kind of the junior member that time. A lot of the guys were AA members who had worked with other physicians, and they said, we don't want to make a big stink about this. Just give some talks at the annual meeting. That will be enough. Physicians will hear you. They're smart people, and they will change. And so we did that for 3 or 4 years, and nothing happened. In fact, the malpractice went up. I mean, we were kind of in an epidemic of more physicians and dentists and chiropractors and nurses getting substance abuse like the general population. And so finally, the association let us do what we wanted to do. They let us start an impaired physicians committee. And what we would do is the nurses, a lot of our reports were from the spouses of these people. We would go and make an appointment at the end of the day with the physician. We'd go out and talk to them, give them what we had heard, and say we wanted to be of some help and what we could do. And it worked. I mean, it worked phenomenally well. And so we took that concept and we started it at hospitals and clinics. I started the first one at the University of Minnesota. I was surprised they let me do that because I was only in my 30s at the time. But that still exists. And the licensure board, kind of like the FAA, got on board with us. I mean, they would send people to us who were beginning to have trouble with their license. Again, that stick and carrot thing. The state licensure board is seeing them when they're in trouble. They've got a stick. The stick is like a hammer. There's only one thing you can do with a hammer. The stick was that they take away their license. They start drinking worse. They maybe could get their license back, but what it did to them was so devastating, hardly any of them ever got their license back. With this system, they maybe couldn't do certain things, or they had to practice under supervision, but they could continue to be physicians. Coming towards the end here, these are my last two substantive slides, enabling and rescuing. Enabling is aiding the problematic use. And I would say whether you're trying to help an individual, or whether you're part of a group, or whether you're running a system, it's very easy to do good in such a way that you enable. And so how do you enable? By providing any kind of use. And why do you enable? For the best of reasons, for the best of motivations, but also from some of the worst of motivations. People who are profiteering out of an alcoholic epidemic or endemic, they're doing it for money. So there's the best and worst of reasons. And why don't they stop? A lot of it has to do with fear. Earlier this year, I was working with a young woman just graduating from college, and she was in the hospital because she was suicidal. So we're having a family meeting. And of course, what we were trying to do is get her into treatment, get the family behind that. And the mother said, no, we want her home. We want her home today. It's Wednesday. The dance, the graduation dance, is Friday. And I mean, it shows you how people want the best thing for their kid. And she looks at her mother and she says, if I go to that dance, I'll get drunk, and the way I feel now, I'll be dead in the morning. Is that what you want? So I was trying to think about what to say, and this young woman had the answer. So I mean, why they don't stop is oftentimes very human, and it's hard for them to stop. You don't just say you're enabling and they all fold up their tents and go away. Rescuing is something else. Rescuing is eliminating the consequences. This is somewhat more subtle, and I think, frankly, it's somewhat more pathogenic or more apt to harm the person in the long run. So people, if they're going to recover, people need the consequences of their damaging behavior. And the more that those are delayed, the deeper they get into their addiction. Some of the sort of miracle cures, I'll call them, because we don't get very many miracle cures in this business, is the person who gets nailed with their first consequence. And one young man that I've known now his whole life, he's probably close to retiring, and he did nail a fire hydrant not far from here, coming home intoxicated after a date. And his father was all over it. I mean, he was going to have to pay the city for the hydrant, but he was going to have to pay his father for the repairs to the car. If he was going to live in the house, he had to be sober for the next year. There were consequences that the city had for him, too. And I mean, this guy, I mean, he almost couldn't recover. The whole world fell in on him, and I think about how lucky he was, because he really has had a fine life. And why do people not do it? Well, I think some of it's messianic. You know, I can cure this person wouldn't lie to me. And it isn't that they're lying, they're making promises, but they can't make promises. To use the aphorism of the addiction robbing their midbrain, I mean, they're not about to be able to make a promise that they can keep. Discussion, just briefly, what have we been talking about? 3 things. The nature of the problem. It's young people's alcohol-related problems, well described, well understood. The extent, if you're going to try and extend, it's very easy for the National Institutes of Alcohol Abuse to write all the material that they did, which is wonderful, but they're writing about the hundreds and hundreds of colleges and universities in the country, whereas if you're working with a college or a university, you got what you got right in front of you, and it's not an average. It's somewhere on that spectrum, and you've got to find out where it is. The other thing is following the plan and getting a plan, thinking about whether you're going to do primary, secondary, or tertiary interventions. Who are you going to try and save, and who are you going to overlook? The level of intervention, certainly you can start out with individual group. It's oftentimes best to make your errors, have your failures cheap, on the cheap, with a group and an individual, rather than start something big and expensive and then have that flop, and everybody gets demoralized. Linking the intervention to the prevalence, planning, implementing, and evaluating, getting to the point where you got a sweet spot, you got something where you have to have a fair amount of success. And success builds on itself. Failure kind of demoralizes. It's nice if you can do something that has at least some success, maybe a little failure to teach you and help you along. And then cautions that really have to do with thinking ahead of time. If I do this, does this really look good? Do I feel good about this? But does it perpetuate the problem? Does it enable or does it rescue? And you can help by contingency contract, but then the person has to ante up something. Just getting people out of jail free really is perpetuating the problem. So, and then my last slide, thank you for giving me the opportunity to talk about one of my favorite topics. And if there's any questions or comments, we've gone on for a fair amount of time. Madam Chairman, or we?
Given the interventions that you've laid out, are we rescuing students? Are we, what is our plan in moving forward? And are there some indicators that we can be tracking as WSNAC to really see, are we getting better or are we getting worse related to this, whether it be epidemic or something else?
Yeah, I think that's a very good question. In my daily work and when I'm teaching students and residents, I think there's a thin line between enabling and carrot in the stick helping. And so a lot of the things that I'm doing with patients on a daily basis in contingency, maybe helping them stay out of jail, or maybe working with them, young guy today, helping keep him in his family, that could be enabling, huh? And at some point, a little hairs will go up the back of my neck, and maybe this is the 3rd or 4th time, and I'm beginning to see this guy's using my influence with his parents to rescue him. And so one of the things that I think you have to be very aware of as you begin working with individuals, to some extent it may be easier to work with groups, but as you're working with individuals and you get committed to those individuals and you want them to get better and you see all the talent and potential they've got, is that you're going to get on the rescue path. And I think I see it quicker now because I'm older and I failed so many times, or I've gone too far with my trying to help, and that's kind of a messianic thing, that if you're a helper, you've got to be able to rein that thing in and let people have the consequences, and then don't rush in to try and save them. So that's not a direct answer. Partly it's not a direct answer because I don't know what you're going to do, and I can't do the tough work for you that you would have to do in thinking about your alternatives and how to approach it. Maybe if you had me or somebody like me, maybe some of the staff, even here at St. Thomas who already work in this field, could be of help to you in thinking through these hard questions. You're asking the right questions, though.
So I'm curious, not that it's a unique culture, but when you're getting young people together right out of high school, many of whom who have developed drinking habits while they're in high school, you get them together in large groups, living together. We have some issues to deal with at the very beginning. Have you seen any models out there, whether they're here in the United States or maybe in Europe, you mentioned Scandinavia, that have been effective in at least trying to address the problem? Because, I mean, while we may have a problem on this campus, there's problems on a lot of campuses.
Oh, absolutely.
And so trying to figure out, I mean, if there's anybody who's identified something that seems to be working.
And there's problems in the military service too, particularly in the Army and the Marines. The Navy and the Air Force have much less. So yeah, you're absolutely right. I think so. I think in terms of locally here, the University of Iowa State, I think it is, in Ames, has done a lot of things over the last decade. I don't know the people down there, and I don't know how they got on this track and what they're doing, but I think some of their interventions appear in the NIAAA materials, and going down there and just seeing if they share their experience, even learning to get to where they are, they had to fail. And if you can avoid doing the failures they had, you really can help a lot. A number of countries have gotten themselves out of a very bad place. So for example, the country in Africa with the highest HIV rate, I always block on the name, actually is doing extremely well at this point in time. About 80–90% of the people who have HIV are in active treatment. They're really going at prevention. They've recently found out that their new target group of people who don't have HIV but are at risk are adolescent girls in that society, a group that they ignored in all of their efforts because this is too hefty, too earthy to deal with girls 13, 14, 15 years of age, and that's where they've got to go. So these are the things that nobody knows ahead of time, and where you do need to go to the people that have tried, learn the best you can. It's still going to be a risk, but Scandinavia has done a lot of this in many legal ways. I don't think they're into as much personal confrontation. If you know the Scandinavians, it wouldn't fit with their culture real well. They might get too many fights, who knows. They're really hefty on laws. So they have huge taxes, not all the, Copenhagen not so much, but Sweden, huge taxes on their alcoholic beverages. Even with first DWIs, you can get a year in jail. Imagine that. Sometimes you can get out after 3 months, but the second one, you'll get a year. Now in the United States, you can get a year with your third or fourth DWI. That was never the case. I think Minnesota, we have patients now getting a year. And so a lot of it is kind of draconian and expensive. You put somebody in jail for a year, it is not cheap. Some of that's working, but I think we could probably do a smarter job.
Kathy?
I thought it was interesting when you were talking about mentored interventions. And I happened to be at Mass this Sunday at St. Thomas at 11. It was the first Mass of the year. And I thought, and I don't know, but Jesse, the priest gave this wonderful homily, and it was encouraging people to talk to one another about abuse and drinking and building relationships. And I thought, my goodness, are they starting right with the where people are at? Now I looked around and there were a lot of young people there, but I thought they probably weren't out last night. This isn't probably the group. But if that group who wasn't out can still reach out to the others, then it starts to change that culture. And wow, I was impressed. I thought, this is a coordinated effort, because I'd never heard that before. So maybe they're starting where they can. So, yeah, trying to permeate. That was very interesting. I did see Dr. Sullivan in the back of the church, too, and I thought, did she tell him to do this or what? But it maybe is just happening. That's interesting. Place to begin.
Any other WSNAC members have questions? Alyssa?
Dr. Westermeyer, we are talking on WSNAC a lot about housing last year and in the years to come. And whether this is true or not, anecdotally, we understand that kids look forward to moving off of campus and into off-campus housing because they perceive they are freer to do some of these things that may be part of substance use disorder. Reflecting on how kids are treated on campus and how we arrange housing, do you have any thoughts on whether it is, what the pros and cons are of residence halls allowing for some alcohol use on campus, or whether a very firm line in the sand that says there will be no alcohol use on campus is more beneficial? And also, as an adjunct to that, should there be substance-free floors or housing facilities for students in a university setting?
I don't know of any really good, I mean, the gold standard is random controlled studies. And this would be a perfect place to do random controlled studies around the country. If anybody has done it, I'm not aware of it. I think if anybody had done it, it would probably be quoted many times and be in many chapters by now. So I hesitate to say very much. I mean, this is the dilemma I think we have in all of these areas related to the new behavioral epidemics. And this is just one. I mean, we don't have leprosy and plague in the same way that we have. They could come back, but we have ways of dealing with them. This is the modern epidemic. It's a behavioral kind of epidemic. And I think we're at a kindergarten stage. We're just learning. I think we do need to learn, but the dilemma is that you could argue it both ways. You could argue it that there should be prohibition on the campus. Now maybe if a campus had an endemic problem, I could see they're going in that direction. For example, right now, quite a number of American Indian reservations around the country they've had prohibition for like 200 years. But now they have real prohibition where the people themselves living in the community don't allow any bootlicking, don't allow any use of alcohol on the reservation after lots of discussion and final decisions about it. There's powwows now, one of them in northern Minnesota, that specifically is a non-drinking powwow. So I think that there's probably more of these prohibition things with horrendous situations. Let me talk about it from the other side. Teaching people how to drink socially and even how to know how much they're drinking, maybe even giving them some blood alcohol levels, things to put on their finger to figure out what their blood alcohol is after 2 or 3 drinks, I think it is a good thing. You know, they're not falling down, they're not getting in a car driving home. So I think but I can't prove it. That's just a private opinion. I think in so many of these areas, we're just naive. And I think the thing to do is courageous people will try and learn, and there's opportunities to learn. My own experience at the University of Minnesota is that probably universities in general are next to the church and the government in terms of they don't want to do it wrong. They want to do it right. And they have a lot at stake, and they do. So the more conservative an institution, the more difficult it is to take risks. But I mean, we learn. We get out of our ignorance through taking risks, in a sense. So how to do that and keep the risk minimized, I think, is the difficulty. And to learn about these things. I mean, if somebody has a study like this, let's see it. And would it apply in a new place, or is it too idiosyncratic to that one place?
Any questions from our audience this evening, or comments? Yes.
To Kathy's question, is there a concerted effort here at St. Thomas for educational programming? Can anyone speak to what St. Thomas is doing to educate our students on campus?
Hand it to Madonna McDermott.
I also want to say thank you. That was an amazing, wonderful presentation. At the University of St. Thomas, we've been doing a lot of what you've been mentioning here, looking at the NCAA, looking at what's been proven in research and what's best practices, and using a combination of models and having it be campus-wide. So there's not just one thing, but many things that are going on. One of the ones that, like you just mentioned, is that it is important for students to know, if you choose to drink, what is a drink, so that if they're alcohol naive, they don't get into trouble. The other is we're now promoting in many different settings and venues that there is a growing number of students that choose not to drink at all. And that we're beginning to see over the last 5 years a trend of that as an improvement. In the last 10 years, there's been a significant improvement. We're now in the 90% that students that don't drink, don't drive after they've had an alcoholic beverage. And so we want to make sure that we're promoting those good decisions that students are making. Other things are in the classroom, and unfortunately one of our professors that does a lot of the lecturing isn't here tonight, but it's on the biology of alcohol consumption and what happens, dispelling the myths. And for students, it'll resonate that this is science. It's not just a parent or another staff person saying you shouldn't do this, but saying if you do drink, this is what happens, and there's nothing that you can do that will change this once it's already in your system. So it's woven into lots and lots of different types of programming. It's woven into the Welcome Weekend and the Tommy Advantage that happens during the first 6 weeks while they're here. And I'm wondering I didn't make it to Father Schneider. Okay, that's really wonderful, because our other Father Blake, he is also a chaplain in the military, and so he comes from it from a different angle as well, that experience there that he can carry over. So including campus ministry, weaving what their message, so that we have a university-wide message. It's still in its infancy, I think, that we're doing a lot of good things. It's not as coordinated as I think it can be, but that's something we're striving for. So I really love the presentation. Thank you.
Madonna is head of our wellness center. Excuse me. Any other final questions or comments?
I just wanted to say I enjoyed your talk, and I hope you get to teach the course with the midbrain sometime.
I'll give it to Rachel to close us out.
You've been a wonderful audience, and we appreciate that you've taken the time to be with us tonight. This has been recorded, and I guess it goes on YouTube, is that, you know?
It will be on the Neighborhood Relations.
It'll be on the Neighborhood Relations website, because there were some people, I think, who wanted to come tonight but weren't able to attend. So that would be a way for them to see it. And thank you all very much for coming.